Good afternoon, everyone, and welcome to our Primetime Live program, Your Heart as You Age. I am Vicki Newell, and I coordinate the program here at Mary Greeley Medical Center. I'm in a room of 150 people with one other person, so since we can maintain 6-foot social distancing, we're not going to wear masks so that you can understand us a little better for the program today. I want to remind you all, if you would like to ask a question, you're going to have to type in your question. So up in this corner here, that should have like a red arrow. If it's closed up like this, you just hit that red arrow. It will pop out a box that looks similar to this. And at the bottom, it says enter a question for staff. Just type in your question there and then hit send. And we will get to all your questions at the end of the presentation. So our presenter today is Dr. Stuart Christensen. Dr. Christensen received his bachelor's degree from Iowa State University and his medical degree from the University of Iowa. He completed his residency at the University of Iowa and a fellowship at the Mayo Graduate School of Medicine. He joined McFarland Clinic's cardiology department in 2007, and I would now like to welcome Dr. Christensen.
Thank you, Vicki, and thanks to all of you who have joined. We'll see if I'm not too old to handle all of technology here and move through this. I don't know if I'm coordinated enough to handle all the questions as they come flowing in as I'm speaking, so as Vicki said, we'll try to save some of those till the end, but I know we always like to have time to go through all of those, so I will try to save time for that. But thank you all for joining. The sun's starting to come out and we're going to get some longer and warmer days. And hopefully at some point we can be out joining with each other without masks and in rooms like this instead of just virtually, but we're not quite there yet. So thanks for joining in. Your heart as you age. Well, that's a pretty broad topic, but we hope we all have hearts and we hope we all age. So it's going to be one of those things that comes to all of us. It's been a long year. There's a lot of stuff that has gone on with the pandemic and lots of illness, lots of death, lots of isolation. Not many times when we're getting together with families, as you can see here in the picture, but we're trying. But one thing that stayed true through all of this is the number one cause of death, despite a pandemic, is still heart disease, cardiovascular disease. And so that is going to come to many of us as we age, but we'd like to age well. And that's what we're going to talk about today. What are the things we need to pay attention to, and what can we do to age better? So we're going to spend some time starting clear on the other spectrum that you might expect as a fetus and a newborn, and talk about some of the changes that occur then that can affect us as we age, and then we'll spend time talking more as we go along. And so this is my newborn daughter 13 years ago, and we're hoping we're teaching her the right habits to move forward, and maybe she can be better off than her grandfather, my father here, who had his first heart attack in his mid-60s. Good man, but probably spent too much time working and not enough time taking care of himself. So I'm trying to learn from that as well and follow some of these things we're going to talk about. So we're going to talk a little bit about foramen ovale closure. So this is something that happens as we're born. Our circulation is different when we're in mom's tummy and then after we're born. And what does that mean as we grow older? And then we're going to start stepping up to some other things that we more traditionally think of as aging things in the heart. So atherosclerosis. If we want to think about an aging structure, think about a home. You're thinking about buying a property that's been around for a while, and you want to really know what is the structure of this and what can be trusted. You want to look at the pipes, the atherosclerosis. What is the plumbing like? How about the foundation, the structure and foundation? And heart failure really talks more about the heart muscle and the function. How about the electrical system? Can you count on things? Is it up to code? Well, that's where the heart rhythm troubles can come on as we age. And then you've got all the really important features inside the home that bring it to life, that are really critical, whether that be lighting or cabinets or doors or whatever they may be. And in some ways we think of valve disease like that. So all of those are really important and critical to maintain in your home and in your heart as you age. So we're going to go back to the fetal heart when we're in mom's tummy and start clear at that extreme and talk about the circulation. So we have the right side of the heart, so the right atrium and right ventricle, as I'll try to point out on the screen. And then we have the left side of the heart, the left atrium and left ventricle. And as we age, the blood goes out to the lungs and from the right side and comes back to the left side. But when we're still in mom's tummy, there's no lung function, there's no breathing air. All of our oxygen and nutrients come from mother. So this is all mixed blood. There is this hole in the heart in all fetus called the foramen ovale. So it's a hole that allows blood to flow from the left or from the right to the left side. And there's also a ductus arteriosus that allows blood to flow from one circulation to the other without going out to the lungs. And that is normal before we're born. But after we're born, both of those things are supposed to close. The foramen ovale, that hole, is supposed to close, and the ductus arteriosus is supposed to close. And that's important because then, instead of this purplish mixed blood, you have your blue blood with less oxygen going out to the lungs to get the oxygen and then coming back to the left side of the heart and then getting pumped out to the rest of the body. What does that all have to do with aging? Well, about 1 in 4 people have a foramen ovale that don't close. Think about that, 1 in 4. You go out to a restaurant, you're at a meeting. If we were usually here in the lecture hall, how many people in here would have a patent foramen ovale, a hole that's not closed? Quite a few of us. So the reality is there's probably family members that we have that have a hole in their heart, a patent foramen ovale. Most of us aren't even aware of that, but it's a very common thing. So as I said, 1 in 4 people have a patent foramen ovale. Most people are asymptomatic. They don't feel bad. It doesn't bother them. We don't do anything about it. We don't go searching for those holes very often. But it can contribute to strokes. And that's why it becomes important as we age, because strokes and cardiovascular disease are so common. So if you have a stroke, one of the things that we look for is a patent foramen ovale. And that's often by doing an echocardiogram or doing a picture of the heart to see if you still have a hole there. Now, just because you have a hole, as I said, 25% of people, 1 in 4 people. So just because you have a hole doesn't mean that's the cause of the stroke. There's many people that are going to have holes if you just look randomly. So that's where it gets to be difficult to know what to do about them. But there is an association with strokes, and as we learn more, we're learning there's an association with migraine headaches. And just in the last few weeks, another paper came out talking about if we close the hole in some people, the migraine headaches get better. The problem is, if we take 25% of the population and they have holes, we can't go close every hole out there because we're going to cause more harm than good. There are complications with these procedures. It's something in the heart, and there's cost, there's risk, and we don't know that anybody's ever going to have problems with those. But we're starting to get a better idea of who we need to do something about, or whose holes we need to do something about. So in general, if you're getting pictures of your heart for some reason, and we do see a hole, but you've never had a stroke, don't have problems, what we usually say is just take an aspirin a day. Simple little thing, an 81 milligram aspirin a day to try to reduce the risk of stroke a little bit. And then in certain people, in certain situations, we can talk about closing that hole. And that's usually done with a catheter. Sometimes it's surgically, but usually with a catheter that can come in from the leg, come up here in the right side of the heart, and we put that catheter through this hole. So here in this picture, you see the catheter coming up, going across that hole, and we call this kind of a clamshell device, but we blow this part or expand this part of the device on the left side of the heart and then pull it back against that atrial septum, and then we expand the portion on the other side of the septum so it just closes up the hole. And then keep you on a little bit of aspirin or blood thinner for a short time. The lining of the heart grows over that, and hopefully the hole is closed and your risk goes down. So that is something we can do in some people, and we continue to do studies and to find out who are the appropriate people and which people are appropriate to close the hole. So that's something that stays open in 1 of 4 people when they were born, that sometimes can lead to strokes and migraines later in life. How about some of the other things we want to talk about? Well, more classically, when we talk about heart disease, we talk about the angina, the chest pain. All of that is atherosclerosis, plaque buildup in the arteries. And that's something that can start at a young age, but can get worse as we move through time. And that's what we want to stay on top of from a young age so that we can age well, live well, and avoid the complications that can occur later in life. So what are those things that we do that can cause problems throughout life? Well, one of the things is we don't pay attention to our own health and our own numbers. Blood sugars, it's hard for us to just walk around and check our blood thinner unless you have a monitor or unless you've been to see the doctor and they've checked on things. So part of it is just following with your routine maintenance, your routine checks with your medical providers to know what is your blood sugar and what is your blood pressure. Is that something that needs to be addressed? I can't tell you how many times in clinic, even in the cardiology clinic, I'm seeing somebody, but their blood pressure is elevated, and they say, oh, it's never that high, and I just ate, I had my coffee before I came in, or I had a salty meal this morning, and we keep ignoring it and pushing it off, but that is what leads to many complications later in life if we ignore those high blood sugars and those high blood pressures. So it is important to pay attention to that even at an early stage. The good old couch potato. I know that never happens to anybody in the pandemic when you're wanting to avoid seeing people and don't want to go out and wear your mask. But, it is something we have to be cautious of, getting our regular exercise and not just sitting at home in front of the computer or in front of the television. Smoking, still a big issue, and it's such a modifiable issue. It's an addiction, and it's a tough one. But it's such a big deal in my world, when people come in and are asking me what to do about this or that with their heart, but they're still smoking, I just have to shake my head because that is such an important factor. If you can do one thing for yourself, don't ever smoke. If you can do one thing for your children or your grandchildren, don't ever let them smoke. And if they are, preach to them how important it is to not. And this is a tough one for me because I don't know if there's a single item on there that I wouldn't eat if I had a chance to. But that's not healthy for us. And it's so easy, especially here in America, to grab something quick. We're spending less time at the grocery store, chatting with our friends and picking out our fresh vegetables because we're in the middle of a pandemic right now. But we have to still try to eat healthy and make healthy choices. All right. You all know all of those things. You're joining in this conference for a reason, because you care about heart disease and you care about your health. But these are all factors that many of us can still work on. So atherosclerosis, this is what happens if you don't pay attention to some of those things. So over here on the left of the screen is a pretty normal artery. You've got the endothelial lining and the inside of the artery. You've got the muscle layers, you've got the external layers, and that's a normal blood vessel that can constrict and expand and allows blood to just flow smoothly through there. But even in our teenage years, we can start laying down fatty streaks in the lining of the vessel and can start laying down plaques as we age. And then as those plaques accumulate, they can start causing narrowing in those arteries. So sometimes when people have angina, if they walk a certain distance and they start getting chest pain and then they stop and rest and it gets better, it's because of plaque buildup narrowing the artery. And often we think it takes more than a 70% narrowing or so to really start contributing to symptoms. But that kind of depends on how big the blood vessel is as well. But that's the plaque buildup. And then the question is, what is the composition of that plaque? Is that a stable plaque, or is that an angry issue of the white blood cells and factors that can cause an unstable plaque? If you think of it more, you'd rather not have any plaque in your arteries, but if you have one, you'd rather have a scar than an abscess, an angry red abscess that's ready to burst. And that's what can happen in the vessels. You can get a rupture of the cap over that, and then that's when you form the blood clot in the vessel, and that's what leads to heart attacks. We're feeling fine, all of a sudden, boom, you get the crushing chest pain because you just had a ruptured plaque causing a clot in your blood vessel. So we like to address this clear back here. Unfortunately, as a cardiologist, I am seeing it when we're at this end of the spectrum, but there are things we can do clear here at younger ages and earlier stages to try to prevent this from happening. So what are things we can do? All of those pictures we just looked at, we can do the opposite of them. We can avoid those situations. The diet, the exercise, stress, monitoring our numbers, our blood sugars and our blood pressures. Medications can be helpful. Once we start moving through these stages and we find out we have some plaque in the arteries, we can do things to prevent this from happening, the rupture of the plaque. So an aspirin makes the platelets slippery. So even if there is a plaque rupture here, you're less likely to get the clot. The blood can keep flowing by there. The statins, the cholesterol pills, they've been shown to cause some regression of these plaques. They can shrink the plaques a little bit, and they can change the content of those plaques, like I was talking about. They can take away the inflammation and make it more of a stable plaque, less likely to rupture. So it's more than just about the cholesterol number, it's about what the statins do to the plaque composition in the arteries. And then sometimes there's anti-anginal medicines to open up the arteries, dilate up the arteries so blood can flow back past there. Again, medicines for blood pressure, for blood sugar. And then sometimes, if it comes to it, we even need to go do procedures. We can do angiograms, sometimes people need stents, sometimes even bypass surgery. So here's our cath lab, where a patient comes in, ideally on an elective basis. They've had a test showing an abnormal stress test, or they've been having chest pains. So we bring them in and want to look at the arteries. Usually this can be done by putting a catheter in the arm, sometimes through the leg, and we thread that catheter up to the heart. And by working out here and looking on the screen, we can see pictures like these. So in this bottom picture, here's a catheter coming in, here's the heart sitting here, and this is the artery, the right coronary artery, and this is a more normal caliber artery, and here's a narrowing, a restriction here, where there's plaque buildup, and then the artery comes back to normal. So this would cause chest pain with just mild activity. This is after a stent was put in, and you can see how much better that looks. That's open and blood is flowing down here more easily. So this is what it looks like when a stent goes in. It's a kind of a titanium alloy mesh wire that is over a balloon, and by inflating the balloon from outside here, we can blow that stent up, and then we deflate the balloon, take that out, and leave the stent. And eventually that stent gets covered with the lining of the blood vessel, and it just becomes part of the blood vessel. So it doesn't take away the plaque. It just opens up the artery, and it doesn't do anything to the plaque in the other areas. So that's why it is so important to do those other things we talked about, the lifestyle changes, knowing your numbers, and the medical therapy and the exercise. Those are the things that have been shown to help people live better and live longer. Okay, so that's atherosclerosis. That's the plumbing in the heart. Now let's talk about the structure and foundation, the heart muscle. Classically, most people think of heart failure as a weak or enlarged heart, and that is a big deal. But with the about 50% of heart failure, and more often in women, it can be normal size heart with normal squeezing function, but it has more to do with the relaxing function of the heart, and that's called diastolic heart failure. Both of those can lead to shortness of breath and difficulties. So here's an example of an enlarged heart, and you can see all the congestion in the lungs. So all the white lacy stuff is fluid in the lungs, and the fluid is layering out at the bottom because that's where gravity takes it. So heart failure can be kind of difficult to interpret, and it's a scary thing if you're told you have heart failure. A lot of people talk to me about that when they see that on their chart or somebody mentions that, and it really bothers them. But heart failure is a syndrome, and really what it often means is you have symptoms, shortness of breath or leg swelling, or signs or symptoms that are related to the function of the heart. And that can be from a structural or a functional problem, so a stiff heart, a weak heart, and it can have to do with either the filling of the heart or the ejection of the blood from the heart. So these are the common symptoms that come along with heart failure. This is more the structure of a normal heart in the middle, where normal size, normal thickness, normal top chambers. We tend to think of systolic heart failure as the more common, but really they're both about equal. But systolic heart failure is the weaker, enlarged heart, where the heart function decreases, the squeezing function decreases. So this left ventricle, the main workhorse chamber, gets weaker, and it's just harder to pump the blood forward, because this is the chamber that pumps the blood to our brain and to our toes and everywhere in between, except for the lungs. That's coming from here. So this is a really important chamber. Now, diastolic heart failure has to do with the relaxing function of the heart. So it's usually not enlarged, but the walls may be more thickened, and it's stiff. It squeezes, and then it just doesn't relax as well. It's a muscle that just doesn't relax. Kind of think about the cramp you get in your leg while you're sleeping at night, and you just can't get that to go away. That's a little bit of like what this is with every single heartbeat. Things that can predispose to both of these are similar. The systolic heart failure may be more commonly due to heart attacks or a virus that's caused the heart to be weak. The diastolic heart failure, is more likely hypertension, diabetes, just the stiffness from overuse of a muscle. And this just shows some of those changes. More of a normal heart. This is kind of an anatomic, pathologic specimen as opposed to the echo, the ultrasound image of the heart. This is what we look at when we do an echo. This is a short axis image from right here in the chest. And this is a heart that's stiffer and thickened. And this patient would have diastolic heart failure. And again, the picture on the echo. And this is a patient who would have systolic heart failure. So an enlarged, weakened heart. All right. So systolic heart failure, or heart failure with a reduced ejection fraction, that's usually when the squeezing function is less than 40%. Just talking to a couple patients today where it still is very confusing, where we think of normal heart function being 100%, but that's not the case. A normal EF, or normal ejection fraction, is 55 to 70%, but usually 55 or 60 is normal. So as the heart sits there and squeezes, it squeezes 55 or 60% of the blood with each heartbeat. So less than that, especially if it's less than 40%, would be a weaker heart, which increases your risk of heart failure. We have lots of medicines that have been studied and proven to be helpful to treat systolic heart failure. And in order to make the heart function better and improve symptoms, we really try to get you on maximally tolerated medical therapy. That's a term we use in our guidelines, but it means even if you're starting to feel better, this is one of those cases where we push the doses as far as we can go without making you feel bad, because we know those are the medicines that help you live longer and help you live better. And then there's diastolic heart failure, or heart failure with a preserved ejection fraction, and that's usually the squeezing function above 50%. And then there's always the ones that are in between, that 40 to 49%. But it's the normal squeezing function versus the weakened heart. And the diastolic heart failure is more often in the elderly women, hypertension, if you're obese, if you have diabetes, all of these things are more common in those patients. Okay, so we've worked through some of these things. Now, how about the electrical system? How about heart rhythm problems that happen as we age? You know, I see young people with heart rhythm problems. A lot of people have skipped beats. I see Iowa State students that come in with their heart going out of rhythm, especially if they had too much caffeine or went on a little binge after finals, perhaps. That can knock the heart out of rhythm. But the causes of that change a little bit as we age, and atrial fibrillation is much more common later in life. All right. So this is a normal heartbeat where you have the little bump before the spike. The bump is the atrium, the top chamber of the heart beating, and the spike is the bottom part of the heart, the ventricle. So lub-dub, lub-dub. And nice and regular walking across the screen, 60 to 100 beats per minute typically. This is atrial fibrillation, which is one of the more common heart rhythm problems we see as we age. So you lose that atrial kick, that bump. Instead of the atrium beating at 60 or 80 beats a minute, it's quivering. It's going over 300 times a minute. And the bottom's typically going fast as well, but not quite that fast. So it's irregular, often a little bit faster, and you lose that atrial kick. So this is the normal electrical system or wiring of the heart, where you have this up on the top left, you have the sinus node, which is the pacemaker of the heart. It's what tells the heart what speed to go, and that sends the signal to the top chambers, the atria, and that signal gets detected here by the AV node or atrioventricular node, and that sends the signal down to the bottom part of the heart. So this tells the top part of the heart to beat. This tells the bottom part of the heart to beat if it's working in normal sequence. But when you have atrial fibrillation, there's often an electrical signal that comes from these pulmonary veins, so the veins that drain the blood from the lung back into the left atrium. There's a signal that can often come from those veins, and if it comes at the right time, it knocks the heart out of rhythm, and it starts all of these little rotors where there's hundreds and hundreds of these little things going around and around in the atrium, their own little circuits. And that's why this is going about 300 times a minute. All of them are bombarding this AV node, and it's smart enough not to send all 300 signals through, but it will often send more through, and that's why sometimes you don't feel very well if you're in atrial fibrillation. All right. I'm not sure why we have that bar there, and I apologize for that, but at least it's not in the middle of the screen, so that's good. So how do we treat the atrial fibrillation? There's two main strategies. One is rate control, where we just leave you out of rhythm, but try to make sure it's not going too fast or too slow. That's been shown to be safe, and for the most part, you don't live any longer by going the other way and trying to put you back in the normal rhythm. It's more, how do you feel? Some people feel poorly if their heart's out of rhythm. Some people feel poorly if they're on the medicines trying to keep them in the normal rhythm and don't notice at all if they're out of rhythm. So treatment is individualized for each person. It's very different. So if we're going to try to just control the heart rate, there's medications we can use, some of the more common medicines here to just slow down the heart a little bit. And there's procedures where we can actually go do an ablation, not the kind that we'll see to control the rhythm on this side, but this is more to just disconnect the top and bottom part of the heart and to put in a pacemaker so that you never notice your heart's out of rhythm. The pacemaker just takes care of the heartbeat. So that is an option if you need to have that done. It works really well. Many times we do try to put you back into normal rhythm a time or two to see if you feel better. And there's a variety of kind of more sophisticated medicines or higher level medicines that we will add. So often we'll start with these over here and see if they work. If they don't, we'll add these rhythm medicines. And then sometimes we do procedures. We can do a cardioversion where we put you to sleep, put the patches on, push a button and deliver energy to restart the heart. And then more and more ablations are moving to a more common procedure. It used to be kind of end of the line if we've tried a whole bunch of other things. And there are people now that are proposing we use that even as a first-line therapy. After your first episode of atrial fibrillation, some people might be better served by just going and putting that catheter up to the heart and finding where those signals are coming from and around those pulmonary veins like we talked about, and isolating those, burning or freezing with catheters. It's a tedious procedure. It's getting better with better technology and techniques, but it takes a while. That's why not everybody rushes off to that right away. But we have people in town like Dr. Sorrentino that do that procedure, and it's a good option if we need that. Overriding both of these strategies is the need to prevent strokes. So it doesn't matter whether we're trying to keep you in the normal rhythm or if we're leaving you out of rhythm, there's still a risk of stroke. We used to think, well, what if we put you on the medicines, keep you in the normal rhythm, and you're doing well, can we stop blood thinners? Well, no, we had multiple studies saying, nope, those people still have strokes. So we try to calculate what is your risk of stroke, and if you are at increased risk, we do everything we can to prevent devastating strokes. And so this is called the CHADS-VASc score. This is what we use many times. Sometimes, if you're a patient of mine, I'll sit at the computer and I'll walk through this with you to calculate your score. Sometimes I'm just doing it in my head, but this is the reason I ask you all these silly questions. But you get points for each of these things. Do you have heart failure? The C is heart failure. H is hypertension. You get a point if you're over 65. You get another point if you're over 75. Do you have diabetes? Have you had a prior stroke or a TIA or a clot? You get 2 points for that. Do you have vascular disease? Carotid artery narrowing. Have you had a stent to the heart or a heart attack before? You get a point for that. And then females. Females are more likely to have strokes. So you get a point for that as well. That's not as strong of a risk factor, but it is still a factor. And so I'm sorry, females, when we start calculating this, you already have a point of 1 before we even asking any questions, start asking questions. So in the many studies that have been done, this is how it all shakes out. You add up those points, and then you see what is your risk of stroke per year. And we know blood thinners, the typical blood thinners we use for atrial fibrillation, blood thinners such as warfarin or Coumadin, or the newer medicines like apixaban, which is Eliquis, or rivaroxaban, which is Xarelto, or Pradaxa. All of those medicines are the blood thinners we use for atrial fibrillation. They have a risk of bleeding in most people of between 1% and 2% per year. So if we're just playing odds, if you're that 20-year-old Iowa State student and you have a score of 0, we're probably not going to put you on a blood thinner for the rest of your life. If you have a score of 1, it's kind of a flip of the coin. And so, if you're just only risk factor is that you're a female, but you don't have diabetes, you don't have those other things, we may not say you need a blood thinner for the rest of your life. As the score gets up to about 2 or higher, the risk of stroke goes up and starts to far outweigh the risk of bleeding with the blood thinners. So that's who we would tend to recommend using a blood thinner. No matter which treatment strategy we use, whether it's rate control or rhythm control, we would still talk about using an anticoagulant or a blood thinner. So these are just diagrams of some of the procedures. This is the cardio version that we would think about using, where we put patches on, we give you medicine through the IV to make you sleepy or forgetful, similar to if you were to have a colonoscopy, same sort of medicine, and just deliver a little shock and the heart restarts, hopefully in the normal rhythm. How long does it stay in the normal rhythm? It depends on the person, it depends on their risk factors, it depends what medications we use. This is the ablation procedure I was talking about, where we go isolate those pulmonary veins, where we take the catheter up there and can burn or freeze with a cryoablation. And this is the procedure that Dr. Sorrentino will often do. So I send many of my patients to her to have this done. This is an AV node ablation, which we do in fewer people, but it can be very effective if people continue to have symptoms where they still can be out of rhythm in atrial fibrillation, but we put a pacemaker in to control the heart rate, and then we just ablate or disconnect the top and bottom part of the heart. So it doesn't matter if this is going 300 times a minute. That signal never gets down here to the bottom part of the heart. And this is a newer procedure. We're just starting to do more and more. We don't do this in Ames right now, but they're doing it in Des Moines and other institutions. One type of device is called the Watchman device, but there's a left atrial appendage occlusion device. Many of the clots, we calculated that risk of what your risk of stroke would be. That would be because those clots form in this left atrial appendage. So it's just this little sliver that sits on the side of the heart from the left atrium, and clots can form there. And then the clots come out here into the atrium. Once they get to the ventricle, shoot out, and it's a straight shot up to the brain. So that's where many strokes come from. Some people really struggle taking blood thinners. They have ulcers or bleeding difficulties. We're finding this is an effective procedure to occlude the left atrial appendage. Again, we go in with a catheter, take that over to the left side of the heart, and put this device into the left atrium and leave it there. You need to be on a blood thinner for a period of time while this seals off, and you form a lining over this, but then this all seals off and reduces the risk or eliminates the risk of a stroke from this area. Now, there may be other causes of stroke, but that can be helpful. So it's not a procedure for everybody. And I know many people want to be off their blood thinners. So many people talk about this and ask about this, but it is becoming more and more common. And I think over the next 5 years, we will be doing more and more of these. Okay, now finally, we're going to hit our last topic, and that's degenerative valve disease. You know, the heart beats how many times a minute? Can you do the math in your head real quick? 60 to 100 times a minute. So how many times a day, I should say? How many times a day does the heart beat? About 100,000. When we have people wear monitors, Some people with slower heart rates are in the 80s. A lot of people 110, 120,000 beats a day. That's a lot of beats. Think of the wear and tear you put on your knees and your hips. We all have our aches and pains, right? And as we go on through life, we're trying to get our 10,000 steps a day in. We get aches and pains. Well, think about the heart, 100,000 times a day of these valves opening and closing. And there's just some general wear and tear. So when we do the echoes, we do the pictures of the heart, there's often a little bit of leakage in a valve. It doesn't quite seal off, so the heart beats and blood can leak backwards. But as things go over time, there can be more leakage or more narrowing, more thickening of the valves, just the degenerative changes that we have to deal with. So this is an example of the aortic valve and aortic stenosis. The aortic valve is supposed to have 3 cusps. Most people are born with 3 cusps. Some people have 2 or 1, but typically 3. They're really crisp and pliable and flap open and closed 100,000 times a day. But sometimes they just get some wear and tear and they get sclerotic, a little thickened, maybe a little calcium, a little bit stiffer, and then they can be calcified and they just don't move like you want them to. They don't open all the way, and even when they try to close, they can't get all the way closed, so blood can leak back. And that's just due to wear and tear on the valves many times. We've worked to come up with medicines to address that. Can we use a cholesterol medicine or something else? But we've really struggled to find a medication to help prevent that. But it is wear and tear and plaque buildup. So doing some of those things we talked about, controlling blood sugar, blood pressure, not smoking, all of those things seem to decrease the wear and tear on the valves. So it's not just the arteries, it may be the valves we're helping too by having a healthy lifestyle. And this just shows the example of as the valves get narrowed, they just don't open quite as far and they can't close all the way. So what do we do if you do have a severely narrowed valve? So aortic stenosis will often just watch, take a listen, do pictures every once in a while until it becomes severely narrowed. And then we will often need to replace the valve. Now that used to just be a surgery, going in and open up the chest and replacing the valve. Now we have catheter-based valves for many people. 8, 10 years ago would have, even 5 years ago maybe, just been the sickest of people would get the transcatheter valve replacement. So if we thought you were too high risk to survive surgery, we'd get that. Now we're moving to more and more data saying this is a safe way of doing this, and we can do that in more people. Not everybody, and it depends on its situation. So many times when we need a valve done, we'll have you visit with the catheter experts and the surgery experts, and everybody will get their minds together and decide what is the best treatment for you. If you do a surgery, you can have a mechanical valve, which might last longer, or you can get a tissue valve, which still lasts a long time and don't necessarily need a blood thinner with a tissue valve as opposed to the mechanical valve where you typically need warfarin or Coumadin. The transcatheter-based valves, they have stents that help to open them up, but the valve itself is tissue and does not typically need long-term blood thinners. How about the mitral valve? Now this is a heart that's kind of laying on its side, so you have left atrium here, blood goes through this mitral valve and into the left ventricle, and then it gets pumped out to the aorta. And as this pumps, the left ventricle squeezes, remember that's the main workhorse chamber of the heart, as that squeezes, the blood's all supposed to go that way, and this is supposed to close. Often there's a trivial or mild amount of leakage, but more than that coming backwards is abnormal. So this would be a moderate amount of mitral regurgitation, leaking the wrong direction. And that can lead to congestion shortness of breath, fluid retention. So sometimes we need to fix the mitral valve, and that can be done with a repair in some people or a replacement. And now we're even starting to do clips where we can go in some people and put a clip and just bring those floppy leaflets, bring them closer together so they don't flop around as much. In certain situations, that can just diminish the mitral regurgitation to help symptoms. Mitral stenosis is not as common. You can just get calcium buildup on the vessels. Rheumatic fever and rheumatic heart disease is the classic cause of mitral stenosis. Unfortunately, we do not see that as often anymore. So these are some of the things that we have talked about. Closing the patent foramen ovale, which is supposed to close on its own when we're born, but sometimes doesn't. Sometimes can increase your risk of strokes and maybe even migraine headaches. And in certain select people, we might even be able to decrease that risk by going in and closing that hole. We've talked about atherosclerosis or plaque buildup in the arteries leading to heart attacks and need for stents and surgery. We talked about the structure and foundation of the heart, either a stiff heart or a weak heart causing heart failure, which is a clinical syndrome of shortness of breath and leg swelling and fatigue. As we age, heart rhythm problems become much more common. I imagine there's many people who are listening in today and watching that have had atrial fibrillation or heart rhythm problems. And then we just get the general wear and tear on the heart valves. So I thought I'd just try this. There's different ways we try to estimate what somebody's heart age is. You know, what do your arteries look like? What does your heart look like? And more importantly, what is your risk of something bad happening? I don't know exactly where this data comes from, so I'm going to put that out there, this particular statement, but I saw several places it was stated that in the US, they estimate our heart age to be about 7 years older than the actual age. So if you're 63, because of the way we treat our hearts are more like a 70-year-old person many times. We used to try to estimate what our risk is in age, we used to use something called the Framingham risk score. Now the American Heart Association has put together a different calculator. And I use this calculator oftentimes when I'm sitting with you in a patient's room trying to decide, all right, what is your risk? You know, your cholesterol's sort of in between, your blood pressure's borderline, you say it's not that bad at home. Well, what is your risk? And how aggressive do we want to be at trying to take care of your heartbeat? So I hope you can all see this and maybe copy this, because this would be something to plug your own numbers in. We'll see if this works. And it does not. I don't know if Tim can help me with that or not, but it's worked on our other computers we tried. So I know the link works, it's just not being allowed here in this system. But what that does is that will, if you just copy that into your browser at home, and you can even just go to the American Heart Association and look up heart risk. But this will take you to a place where you can calculate a score, and we'll see if we can make it work. But you plug in all those numbers we talked about. You plug in male or female. You plug in your age, your blood pressure, your cholesterol. Are you taking an aspirin? Are you on a statin? You plug in all of those numbers, and it calculates a risk. You are at 15% of risk of developing cardiovascular events, heart attacks, strokes, needing a stent over the next 10 years, or you're at 2%. And that helps us decide what medicines and how aggressive we should be at taking care of you. It's really an individualized conversation. The American College of Cardiology and American Heart Association say if we plug your numbers in and your risk is over about 7.5% 10-year risk of an event, we should think about treating your high cholesterol with a medication and not just diet and exercise. We should think about being more aggressive with blood pressure medicines. So I'm sorry that didn't work. It worked when we tested it, but you have that there and you should be able to plug that in and see what your own risk is. So that's just some discussion from here at Mary Greeley, extending out to wherever you are at. We're trying to provide the best service we can for you, but I'd prefer you just start at that one end of the spectrum and take care of your heart, so you don't need to come in and see us as often in the cardiology clinic, but we want to be there if you need it, and we have lots of tools and techniques and risk calculators and data and all kinds of things we can use to help understand your heart as it's aging and you as you age and help you age better. I think we'll do some questions.
Yes, I know. Yep, you just expanded it there for you.
Okay. So how is plaque composition? Is there a way I can open them up to see it? Oh, there it is. Gotcha. And how is it to know if my plaque is angry? You know, so that's such a good question. And there's a lot of researchers working on that right now. We know just in general that if you smoke, if you have higher cholesterol, if your blood sugars are poorly controlled, your plaque, you know, if we just, again, take the data and group it together, if you do those things, your plaque is going to be more white blood cells and clotting factors and angry plaque. We've tried to come up with MRI techniques, PET scanning techniques, or things where we can do tracers to taken up into certain types of plaque so that the hot plaque will show up. And sometimes our CT scans do some of that, but we're still working on that. So the best we have right now is just to try to control the risk factors.
And will you read the question first?
Yeah. So what is the reading for high blood pressure? And what if the elevation is systolic and is intermittent for hours or a few days? Yeah, so those are good questions. We know lower is better in general for blood pressure. So a lot of times we'll say we start medications if you're over 140 over 90, but even a 130 over 85 or even above 80 would be considered high if you look at the guidelines. We focus a little more on lifestyle changes at that level, but truly, even if you have a blood pressure of 124 over 80, your risk is probably higher than somebody with a blood pressure of 110 over 65 or 70. So getting both numbers lower is good. There's obviously, it's a J curve. You get down too low, we don't want you passing out. We don't want you too tired. So we have to find an in-between. But trying to get those numbers, you know, a 110 over 60 is a great blood pressure if you're feeling okay with it. Intermittent blood pressures up and down, I usually say check it after you've been sitting down for about 5 minutes, and you can check it multiple times because that will often drop as you're sitting there. We know everybody's blood pressure does go up as you go do things. When I put people on a treadmill, the blood pressure goes up, and then it comes down pretty briskly after they sit down after the treadmill. So it's typically measured at rest. I am taking amlodipine. Do I still need an aspirin a day? So separate questions. So amlodipine is for blood pressure. You want to know what your blood pressure is. The question then is, do I need an aspirin? And I didn't spend a lot of time on that today. It's another whole discussion. It depends why you're taking the aspirin. Is it primary prevention or secondary prevention? And there's a lot of controversy about this, but some research the last few years has helped. We used to say, you know, kind of like an apple, aspirin a day keeps the doctor away. But there is a risk of taking an aspirin. You can get ulcers, you can get bleeding. So if you are a healthy person and you're just taking an aspirin because, you're 25, but your grandpa had heart disease and you don't want a heart attack and you're taking an aspirin, the bleeding risk might outweigh the benefits you get from that. So if you haven't had cardiovascular events or you don't have heart disease, you may not need to take an aspirin. But then some people have taken that data when it came out a few years ago and said, well, I don't need an aspirin. There's a lot of data saying for secondary prevention, if you are somebody who has had a stent before, you've had bypass surgery, you've had strokes or heart attacks, or even if you have plaques in the arteries in the neck or the heart, an aspirin is probably more beneficial for you than harmful. So what is the significance of tricuspid valve prolapse with regurgitation? So tricuspid and mitral valves are the two valves between the top and bottom chambers. The mitral valve is on the left side of the heart, and that's kind of the main workhorse system that pumps blood to the whole body, so the pressures are higher there. Tricuspid valve is on the other side between the top and bottom chambers, and that is the lower pressure system pumping blood to the lungs. So to be honest, our bigger concern is mitral regurgitation, because that's the higher pressure system, the more important system. And if that's leaking, that's going to send blood back into the lungs and cause shortness of breath. The tricuspid valve, if that's leaking, that tends to cause blood coming back into the legs, and you get some leg swelling, and we just need more diuretics. It's not as common that we have to do surgery or do a procedure just on the tricuspid valve by itself. Now, if we go in and fix some of the other valves, oftentimes we will just tighten that up as well. One caveat is when we put pacemakers or defibrillators in, we come through a vein, and to get the wire to the bottom part of the heart, we go through that tricuspid valve. So we go through the top chamber, through that valve, and put the wire into the bottom part of the heart. And so that wire sits there, and sometimes the valve cannot close completely because the wire is getting in the way. And that can be a cause of tricuspid regurgitation, and sometimes we actually have to go in and tighten that up a little bit surgically. All right, I'll keep going with a few more until you tell me to stop. Is there some calcium test or score you can do? Great question. Yes, there is. Calcium scoring is something we do fairly often. It's just a low-level CT scan, low energy, low amount of radiation. It does not tell us much about the arteries themselves. It's different than the coronary CT angiograms that we do. That's a more sophisticated test that needs to gate the heart, and because the heart's a moving structure. This is just a snapshot of the heart, and we circle all the calcium deposits in the arteries and calculate a score. And the higher that score, the higher your risk of developing cardiovascular events. And there's a big database called the MESA database that we can look at and see, all right, what is my calcium score compared to other people my age and gender and ethnicity? Because, my son's calcium score should be less than mine, and hopefully mine is less than my father's, because we all are a little bit different. So it's not only the number, but it's where do you rank compared to others of your age, gender, and ethnicity. Insurance does not cover the calcium score very well. It's $100 to $200, and we can do those all the time. So a lot of times that's out of pocket. Again, it doesn't tell you whether a plaque is 90% narrowed or 10% narrowed, but it tells you about risk. So in some ways, it's like checking your cholesterol and checking your blood pressure, but it is a little more specific to the heart arteries. How low is too low for blood pressure? And I don't know if my answer is correct, but when I'm telling my patients this, it's usually, if you're feeling bad, it's too low. Truly feeling bad. Now, none of us want to take more medicine, but the lower the blood pressure, the better off you are. Now, and most people on blood pressure medicines will get a little lightheaded if they get up too fast. But if you're passing out and hitting the floor on a regular basis because your blood pressure's too low, then we need to fix something. If you're not on medicines and your blood pressure is just low and sometimes we have people with just hypotension or people with nerve disorders, Parkinson's, those sorts of things where the blood pressure just is low, especially when you're standing up. We have some medicines to raise blood pressure, but we don't have good medicines for that. We don't have good procedures to raise blood pressure. But a lot of that, it's not a number about too low, it's symptoms. How do you feel? All right. I'm glad somebody was able to get the risk calculator to work on their laptop. Appreciate that. I'm sorry we couldn't get that pulled up, but hopefully you have the link, and it sounds like somebody was able to get that to work. Okay, I think that's all of our questions.
Yeah, and I'll pop in. And
all right. Thank you, Vicki.
Yeah. Well, thank you, Dr. Christensen. Your programs are always very informative. Thank you. Thank you, everyone, for joining us today. I want to remind you, we have a couple programs coming up in March. The first one's Friday, March 19th, osteoarthritis and lower extremity joint replacement with Dr. Steffel. And then the impact of aging and exercise on immunity, and that's March 31st at 2 p.m. And that's Marion Kohut from Iowa State University Kinesiology Department. So once again, thank you, Dr. Christensen. Have a great day, everyone. Thanks for joining us.